Good afternoon. I'd like to welcome you to today's Medical Center Hour, a program titled Care Inside the World of Elder Home Caregiving. I'm Marcia Day Childress. I'm from the Center for Biomedical Ethics and Humanities here in the School of Medicine. We bring you these weekly Medical Center Hours throughout the academic year. A diverse population of caregivers working in clients' homes constitutes a vital link in our healthcare system. I use the word system advisedly. These people's services fill a gap between institutional care and what families can manage on their own. But who are these caregivers? What is their work? And what does it mean to them, to the clients and families they serve, to the healthcare system, and to our larger society? A remarkable documentary film entitled Care, made by Deirdre Fishel in 2016, probes these questions and their implications. The film, which aired earlier this year on PBS, offers finely nuanced narrative profiles of 5 caregivers, their elderly clients, and the challenging contexts in which they interact. Prompted by this film, our Medical Center Hour today inquires into the nature and lived experience of home-based caregiving for elders, what we know about it, what we need to do to improve it. What role does such care play as our population ages and as people with care-intensive medical conditions seek to stay at home? How does home caregiving fit or not with our current medical management of the frail elderly? How can we better value and compensate care workers and better support those individuals and families who need their services? And what about the sustainability of the home caregiving economy and its workforce? These are tough questions that we won't necessarily answer today. But we will go briefly inside the world of elder home caregiving to tangle with its realities, its personalities, its challenges, its costs, its burdens and benefits. We'll let Deirdre Fishel's documentary open our inquiry. We'll actually be viewing the opening 15 or so minutes of this 1-hour film. Then we'll consider a range of perspectives on elder home caregiving. First, on my immediate right, from UVA medical student Michael Warwick. Next, from UVA Public Health Sciences professor Erin Yao, who's seated in the middle. And finally, from UVA family physician, geriatrician, and medical humanities scholar, Dr. Justin Mutter, on my far right. None of them had any conflicts of interest to disclose. And then, of course, following all of those perspectives, we will hear from you. So I would like to thank the Department of Chaplaincy Services for partnering with us on this program. And we'll start with the clip from Care. Thank you.
It's a pleasure to be here today. I have no financial disclosures other than I am in tremendous medical school debt. I'm here today to share with you my experience as an in-home elder caregiver. This is a job I ultimately acquired while applying to medical school. I was working part-time as a teaching assistant in organic chemistry, but I really needed some supplemental income. And as a non-traditional applicant, I also wanted to do something to show my commitment to medicine. And after struggling to find that something, I learned about a local agency much in need of male caregivers, and the rest is history. I ultimately spent the majority of my time caring for 2 elderly gentlemen. These proved to be 2 drastically different experiences, both which I will touch upon. Initially, I filled in temporarily as caregiver for a gentleman in his late 80s. I had been a very prominent lawyer, lived in an upscale independent living facility, now with significant dementia. I vividly remember my first day. I was quite nervous, felt largely unprepared. I really didn't know anything about medicine that I hadn't learned on Grey's Anatomy. But this gentleman was sitting in his wheelchair watching the Weather Channel on repeat. There was very little communication. I slept throughout most of the day, and he really required full assistance 24 hours with all activities, eating, bathing, drinking, toileting, transferring. I'd never really done any of these things before. He was also an aspiration risk, which was worrisome. Ultimately, I was really just filling in for his regular caregiver, and he made it quite clear that he didn't want me there. The first evening, he sort of began to sundown, became quite agitated, told me to leave immediately. I seriously questioned, what I'd gotten myself into. I was scared as to what could go wrong. But the next day, I vowed to return, and slowly we began to build a relationship. He continued to sleep most of the day, and despite my best intentions, he would only watch the Weather Channel. But we began to make small conversation, and I was able to provide a devoted ear as he recounted stories of past presidents he had known, of exotic travels he had taken, his experience hitchhiking across the United States, and so on. He lived in a facility which provided full-service dinner each night in the dining room downstairs, and he apparently used to enjoy this very much, but had stopped attending prior to my arrival. So I decided that this was something easy enough that we could do together, and as I began to build trust with him, these nightly dinner outings became our go-to activity. He would pick out suits and sport coats from his closet, many from several pounds ago, and I would painstakingly fit them on, and downstairs we would go to dinner. Although this seemed like a small thing, I felt it was really important in having a routine and having the opportunity to socialize with other residents, and he really seemed to enjoy this time. But just as I was beginning to form a bond with this gentleman, I received a permanent assignment with a different client, which proved to be a very different experience. I thought I would briefly share an excerpt from my personal statement, which summarizes this relationship. The bell rings one last time. Mr. M, 80 years old, is ready to begin his day. A retired engineer with an impressive resume, Mr. M is home, humbled by a stroke, and I am his caretaker. This is a job I acquired by necessity, but have since come to cherish. Though my medical knowledge is minuscule, the deficits he experiences are obvious. Yet day by day, we push through the frustrations, refusing to accept defeat. When the time comes to say goodbye, there is joy in Mr. M's voice, progress in his independence, and one might say there is rehabilitation. This gentleman was very determined to get better, very optimistic, stubborn perhaps. Cognitively, he was without impairment, but physically he was very weak and deconditioned. He had a history of bladder cancer as well as breast cancer, and now was recovering from the deficits of a stroke, necessitating 24-hour assistance. I would spend almost a year with this gentleman as his primary caregiver and companion, and we did nearly everything together. There was little off-limits, activities of daily living, bathing, dressing, toileting, ambulating, as well as so-called instrumental activities of daily living, housekeeping, laundry, shopping, transportation, meal preparation, and so on. He was also very determined to drive again, and I may or may not have agreed to let him attempt at one time in an after-hours parking lot, but he soon realized he had no business driving, but needed to know that he had tried. I also very much became a liaison for his family. I feel I was able to provide a source of comfort and security for them several hours away. When I first began working with him, mobility, balance, dexterity were a tremendous struggle. He couldn't dress himself, really had difficulty feeding himself. Many days his legs just wouldn't cooperate. But we began to work on these things each day and began doing daily exercises after breakfast. Initially, kind of standing from a chair, balancing by the sink and so forth, using a gait belt and a walker with really full assistance. And gradually he was able to use the rollator with little assistance at all. As his strength improved, we set goals, first of walking to the mailbox each day to retrieve the mail, eventually to the end of the street and back, and later to attend classes at the senior center and return to church. Our days, weeks, and months even were not without setbacks and frustration, but with some physical and emotional support, he was able to accomplish nearly all of these things. Perhaps my fondest memory of this relationship has to be the romantic relationship that he was able to cultivate with a neighbor. She would come to visit several times per week for lunch or dinner dates. I have a few tricks up my sleeve. I'm no gourmet chef, but I would prepare all their meals and didn't receive any complaints there. On Sundays, they would have movie night. I'd fix popcorn and ice cream sundaes. It was honestly like watching two teenagers fall in love for the first time. I'm not sure that had been possible had I not been able to stay at home. There were certainly less glamorous days. When it would snow, for instance, I would sometimes spend 36 hours there consecutively to ensure there was no lapse in coverage. can really be quite isolating. You're largely cut off from the rest of the world, unable to use your cell phone or computer, really, with the exception of emergencies. And it's difficult to even, step outside and take a break. And then there were the dreaded night shifts. My client had severe nocturia following a partial cystectomy and BPH, and nearly every hour on the hour from 9 until 7, he would ring his call bell, take off his CPAP and shuffle unsteadily to the bathroom, too proud to use a urinal or bedside commode. Meanwhile, I'd be there right behind him, and 15 minutes later, he'd be back in bed for only a short while. In the end, you do what you have to do. I remember fighting back tears on my last day. I had become very attached to this gentleman. I think it's inevitable after spending any significant amount of time caring for someone in such an intimate and personal way. I worried about what would happen to him after I left, who would care for him next, and I hoped that he would be able to continue to stay at home for as long as possible and do the things that he enjoyed. I firmly believe the benefits of an elderly person remaining at home, so long as it's safe and attainable, cannot be underestimated. This experience truly taught me the value of aging in place, of maintaining routine, a sense of normalcy and independence, of waking up each day in an environment that is comfortable, secure, familiar, of having continuity in caregiving, and ultimately being able to maintain relationships in the community. At the same time, home care is not without its challenges. Although I was relatively young, single, didn't have a lot of responsibilities and a second job, this can be a difficult way to make a living. I also had the benefit of knowing that my time was finite and I would be going back to school. For others, I'm not sure it's quite so easy. There's some flexibility in scheduling, but starting pay was around $8 to $9 an hour, no true benefits or overtime. In total, I was working about 70 hours between my two jobs, which is probably an easy week for most of you all, but many of my fellow caregivers definitely seem to be struggling, trying to hold down multiple jobs with tenuous transportation situations and so forth. The work itself can definitely be very physically taxing as well as emotionally. Certainly a degree of social isolation, as I mentioned, and at times a real lack of intellectual stimulation as well. And I think on the harder days and nights, one can easily question whether the work they're doing is truly meaningful or making a difference. But in the end, caregiving is truly a labor of love. I am very thankful for my experience and relationships I was able to foster. In the first case, my work was more about sort of minimizing the complications of dementia, trying to maintain orientation and maximize the quality of life the best I could. In the second case, it was really about getting better, setting goals, becoming more independent, and limiting the amount of care necessary. I certainly like to think that my time as a caregiver, has made me perhaps a more compassionate, patient listener. It's certainly given me a much greater appreciation of the challenges, faced by families and other caregivers outside of the hospital every day, and of the thankless work that happens both here and at home, all across the United States. And just lastly, I think this work has undoubtedly influenced my career decision to pursue a career in physical medicine and rehabilitation. Thank you.
I'm Aaron Yao. I'm a health policy researcher. So I'm going to talk from the health system level. This is very different. Well, so I do a lot of research on home-based medical care. So I know the homebound population. There are about 4 million Americans are completely homebound, and there are more partially homebound. So that's the clients, Michael was talking about. And so these homebound Americans, most of them are elderly. They oftentimes they have multiple conditions like hypertension, diabetes, COPD, cancer, dementia, and other issues. And not just they got lots of health conditions, but they also have functional limitations. So that kind of create the problem, the homebound, home limitedness for these people. And for these homebound elderly population, they receive very fragmented care, okay? Like the people work at home, like all the healthcare professionals work at home, they try to keep people at home, right? We see the statistics from the video talk about 90% of people want to age at home. And we also have data that about 70 of Americans want to die at home. But you know the data is it's only about 30% of Americans die at home. And other people, they die at hospitals and other institutions, okay? So they receive very fragmented care. So that's why oftentimes they can't control their symptoms, then they end up at the emergency and the hospitals. And actually, these people are among the mostly costly patients in the United States. So they're among the top like 5%, costly patients in the United States, but they spend about 50% of all the healthcare costs in the United States. So it's very easy to understand, because if you don't take care of them at home, they end up at the emergency and the hospitals. And if you ask some house call doctors, you will know that a lot of patients, if you don't get care at home, they will use like a few or even like 20 ER visits or hospitalizations in a year. So it's very, very expensive. And so that's the situation. That's the need for home care. And so in the flyer, you see some of my papers or news reports about my research in home-based medical care. So so for providing care at home, we should have integrated care, but we don't have that for now, because like I'm doing research about the home-based medical care, but there are also home care agencies are doing the nursing care and the therapies, and then there are also personal care, right? So it's not integrated in the United States for now. Medical care, nursing care, therapists, and personal care. We really need to integrate them, but we have a bad system, we can't do that. And also it's underpaid for all of this, almost all of this, like medical care and the personal care. So for personal care, I have some data to tell you. So in 2014, there are about 1.6 million personal care aides, these people, workers. So this number doubled in 10 years, and I think it will continue to grow. But they are only paid about $10.42 per hour. And at the same time, in the United States, the average hourly wage is $23.23. So it's not even half of the average pay. And half of them are part-time. And 85% of are female, and 49% are white, 21% black, and 19% Hispanics. And about 24% of are foreign-born immigrants. So that's the data for the personal care workforce. It's the value of personal care and other care at home. It's not really recognized by payers. So I do more research about Medicare, I can tell you. So for office visit, you're paid about maybe $120 for an office visit. But for a home visit, a house call visit by a doctor or nurse practitioner, is only paid about $160. So the difference is only about 30%. In Taiwan, it's 5 times difference. Okay. So personal care, the same thing. It's only like not even half of the average pay in the society. And we really want to keep people at home, because that's actually the most comfortable place you want to live. Because for healthcare or any kind of care, it's not just about adding years to life. It's really about adding life to years, right? You want to have some quality in your life. Actually, there was a study by Penn. They actually surveyed chronic ill patients about just one question: do you feel like your life is worse than death? And about, I think 30% of nursing home residents, they think their life is worse than death. So that's why we need to keep people at home. That's why we need the home-based medical care, nursing care, therapists, and the personal care aides. And you see in a video, the personal care aides is taking patient to doctors because we don't have enough doctors providing care at home. And so in comparison to the workforce of personal care, we have a huge shortage of home-based medical care, huge. Only about 12% of the homebound patients have received a medical care at home. Only 12%. So that's the data in my working paper will be published soon. So, well, I can talk about this probably for a whole day, or because that's my passion. Try to provide coordinated and integrated care at home, and try to keep people at home and enjoy life, and at the same time keep the healthcare costs low. So, and if you have questions, then later we can talk about it. I want to save some time for my colleague Justin. He's doing some house cost business now.
Thanks, Aaron, and thanks, Michael. So, they've provided us, I think, a great window into the profound experiences of the caregiver. And Aaron sort of given us a bird's eye view of what's our system like and how is this all working or not working more often than not. I want to shift and sort of build off of those foundations and sort of ask, why are we not doing this work better? Those of you who know me in the room know I like the why questions. And it strikes me that it's not something that we often try to answer. There is a huge gap, as we've heard, between what is needed and what currently exists. And it's almost like we're watching a fault line shift in real time. I mean, that gap is growing by the day. And yet, as a society, and I think this is true both nationally and internationally, and Aaron can speak to the international perspective as well, we're not even near where we need to be on this. And we need a film like this to help navigate us back on track. So I'm going to try to answer that, and I'm going to talk a little bit about the future of caregiving in that context. And to start, I'm going to borrow an artistic metaphor, since we're talking about film. And that's the metaphor of framing something. And in his famous essay, Framing Disease, and this is Charles Rosenberg, who's an American historian of medicine. He published this about 2.5 decades ago. It's still very timely. And it reminds us of the extraordinary power unleashed in the naming of a disease or the naming of a problem. And he says, it's a little bit of a long quote, but I want to read it all. I think it's really important. He says, disease is an elusive entity. It is not simply a less than optimum physiological state. The reality is obviously a good deal more complex. Disease is at once a biological event, a generation-specific repertoire of verbal constructs reflecting medicine's intellectual and institutional history, an occasion of and a potential legitimation for public policy, and an aspect of social roles and individual identities, a sanction for cultural values, and a structuring element in doctor and patient interactions. In some ways, disease does not exist until we have agreed that it does by perceiving, naming, and responding to it. So that's a mouthful, it's a lot. And I'm going to try and unpack that a little bit. So Basically, to frame a disease is to begin to understand it as an issue that we can do something about. So for example, we label a disease an epidemic or an emergency. Think about our current public challenges and just trying to decide, is the opioid crisis an emergency? Is it an epidemic? We do this every day. Or think about the history of Alzheimer's disease, for example, where when we frame a disease in this context of dementia, we assign to it a very specific cause, and that assignment allows for healthcare dollars and research dollars to be mobilized. So for example, it was not really until the late 1980s, 1990s when we decided that Alzheimer's disease was a disease entity that we began appropriating significant amounts of money to its research. So the process of framing a disease has tremendous power across multiple domains of our lives. And as Rosenberg suggests, how we frame a disease affects how medical providers are trained, how diagnoses are made, how and what treatments are offered, and how healthcare is financed, to name just a few. So not surprisingly, this wide-reaching power can be used both for good and for ill. So what does this have to do with caregiving? I would suggest that a large part of the blame for our failure to meaningfully support caregivers rests with the way that we have framed caregiving as a society. In fact, the notion of caregiver burden is about 3.5 decades old. And yet, as this film makes clear, and as Michael's experience makes clear, we've done very little as a society to ameliorate that burden. Why? So let me offer a preliminary answer. I think it's because rather than frame the tremendous tasks of caregiving as social and health systems challenges, we have framed caregiving largely as a disease, or more accurately, as a major risk factor for disease. And so I don't have time to go into all the history of this phenomenon, but if you look at our research enterprises, our patient advocacy organizations, even our grant-making institutions, we tend to reinforce this narrow framing of caregiving as putting the caregiver at risk for certain kinds of diseases. One prominent publication from 1985 in the Archives of Internal Medicine referred to caregivers as the hidden patients. We have since created countless scales and measurements of caregiver burden, screening tools, other methodologies to define it, capture it, and utilize it as a construct in our research. And I'll quote, "Caregiver burden can be measured in terms of discrete dimensions of well-being." That's from an article in the Gerontologist in the early 1990s. Arguably one of the most prolific researchers on caregiving who's still working today and has published mountains of research on caregiving for the last couple of decades, is now focused on measuring specific biomarkers among caregivers that correlate with stress and health outcomes. So caregiving is now like bad cholesterol. We need to know what our numbers are objectively so that we can mitigate our risk. We have medicalized caregiving. Well, as a geriatrician who has the privilege of working with families and caregivers every day, I have a feeling that these endeavors might appear profoundly tautological to caregivers themselves. They tell us what we already know, and they reiterate what we have already said. That's not to say that they're not important, and I want to make sure I make that distinction. These insights into caregiver burden and the very real impact that they have on caregivers themselves are quite significant and have formed the foundation for several programs for caregiver support and mental health. The problem is not with the notion of caregiving as a health risk in and of itself, but rather the fact that with our emphasis on the biomedical effects of caregiving, we have neglected the caregiver as a whole person, not to mention neglected the specific features of our social and health systems that make such a neglect possible. And that's what Aaron called our attention to. And this is because framing, and especially our tendency as a society to frame social problems like caregiving as medical ones, is essentially a reductionistic enterprise. For us, this means that caregiving is too often framed in biomedical rather than biopsychosocial terms, and as an individual rather than as a family and community problem. This must change. What this documentary and stories and experiences like Michael's reveal is that caregiving is first and foremost an art and a journey. An art, and as art, it is filled with the complex features of tragedy and comedy, of sorrow and joy, and of confusion and clarity. It is, in short, a profoundly human and humanistic activity, whether in its physical toil or in its emotional and spiritual connections. Seeing caregiving as an art means placing it on a trajectory, navigating profound uncertainty in late life with an arc toward the certainty of death. As each of the 5 stories in this film reveal, and I would encourage you to watch all of them all the way to the end, these journeys are indeed very burdensome, but they are fundamentally corporate journeys. They're not individual journeys. Caregiving is at its core not about biomarkers, but about relationships and partnerships. So I think this film helps us start a conversation toward reframing caregiving as a concept. This wider concept of caregiving is a relational, journeying art, and it calls us to build more person and community-centered systems of care. The future of caregiving will require demedicalization and rehumanization and socialization of caring. This means, among other things, building robust medical, social, and financial services, the kinds of integrated systems that Aaron is talking about, around older adults in their homes. And that will be no small task. But with caregivers like Michael and the remarkable individuals in this film leading the way, the future is bright. Thanks.
Okay, we have, thank you for those presentations, and we have time for conversation among you and with you and with our panelists. When you ask your question or make your comment, please identify yourself.
Hi, I'm Nikki, and I'm a med student here. And I was just wondering, my experience is in a nursing home as a CNA as opposed to home care. And of course, nursing home living is far from ideal, but there are a lot of things that nursing homes have that make it a lot easier to care for residents, like the beds that go up and down with a push of a button, and the Hoyer lifts and the sit-to-stands that can get people in and out of bed easily. You've got the reusable incontinence pads and the industrial-sized washing machines and all the little doodads that you need to, all the supplies you need to take care of people who have trouble with ADLs. And I was just wondering, does Medicare pay for home modifications and things as expensive as Hoyer lifts, or is that another barrier to keeping people in the home as they age?
I can start first. So thanks, Nikki. Great question. I think that certainly I don't think any of us mean to suggest that skilled nursing and long-term care is not very important and a very important service for certain individuals. I think more often than not it becomes the only choice for certain individuals who nonetheless would prefer to remain at home, despite the fact that that they are quite aware that the kind of care that they could get in their home may be, less than standard compared to what they might get in a skilled nursing facility. The financing of this is really challenging, and Aaron can maybe speak more to this, but so as some of us may know, Medicare pays for short-term skilled nursing care, but not long-term skilled nursing care. Medicaid pays for long-term care, which both is in the home, can be in the home and or in a facility. So this makes the financing of this quite difficult, particularly in the personal care. I mean, the vast majority of personal care is paid for out of pocket. So, so we really, as Aaron alluded to, the financial systems in the fee-for-service world that we're facing are significant in terms of trying to move this forward and help provide this care.
I will quickly mention one thing from the film. You saw Peter Sturdivant, the CBS News editor. He and his wife, as the film goes on, have to work out a way to go onto Medicaid in order to continue to afford the home care that has become so necessary for him, and that was a difficult thing. Aaron?
No, we're not against nursing homes. And for the Medicare payments, Medicare definitely pays for a lot of the medical equipment we need. But of course, you will need a provider actually know what you need, and especially it's better to have a household provider to inspect the home environment and then prescribe this kind of durable medical equipment.
Bob Chevalier, I'm a pediatrician at UVA. So how have developed countries with socialized medicine like Canada and European countries addressed this? Because it sounds like the finances and the organizational aspects are key, or at least a step towards that. And you said that Taiwan pays 5 times as much as America.
So I'm doing the international comparison right now. So like in Japan, they have a different system too, a payment model. Even in the Medicare program, they have 2 different models. So the traditional fee-for-service is just pay by volume, and with Medicare Advantage, some household organizations, they sign contracts with Medicare Advantage program to, and the payment is it's per member per month. So the providers, they only focus on the quality of care and don't need to worry about documenting and billing. So in Japan, they have both too. But of course, the price is always not the same. And I haven't started to look at Canada and Australia, but I will look at their model too.
Yeah, I'll add to that briefly. So I think one of the big differences in terms of the United States versus other settings is what we call something like the percent of primary care spend. So generally speaking, our percent of primary care spend in this country is relatively low compared to other industrialized nations. And what that means in real terms is that many primary care physicians, no matter kind of who their patient population is, are finding themselves sort of busting at the seams and to get people, see enough people to kind of make ends meet in a half day or a full clinical day. And in that context, it's very difficult financially to go out and do a home visit, as you said. Whereas in the UK, for example, where you're not on the fee-for-service system in certain ways, you don't have a disincentive to go do a home visit if you want to. So, so the incentives and disincentives are pretty profound.
Other questions and comments?
My name is Penny. I work as a nurse in infectious disease. I worked for many years in nursing homes as a per diem agency nurse. I'm very impressed with the young student for doing the care and for you to do the care as a CNA. I was a CNA briefly, worked with 2 elderly sisters in their home in their 90s. And I became a nurse because I love the elderly. But it was so disheartening and became impossible with my back surgery and just the workload in a nursing home of walking in and having 30 patients, 35 patients. I used to be kind of jealous of the activities director because they could have quality time, to hang out with the patients. And all I could do was, hi, Mr. Jones, here's your medicine, please take it, and a quick, as much as I could get out of it because, it's rewarding. But our system, again, I've tried to understand how and why, but it is a system that is broken because it's dangerous for the nurse and their nursing license. It's dangerous for the patient. You give the best care you can give. I know in the state of Oregon, very progressive, they would have mandated numbers for the CNA on evening shift. They could have a maximum of 13 patients, etc. But I remember walking into a nursing home one night shift, which was very rare. It's probably the last time I walked in. I was the only nurse. I had 130 patients. So it should not be legal.
Yeah, I mean, it's a key point here, and I think we underestimate as a society and as a health system the degree to which the physical toil and emotional engagement that personal caregivers provide actually makes people better. Much more than any medicine that I can write for, right? So I think, and this is kind of Aaron's point as well, is that when we think of care as an integrated phenomenon, from the level of personal care to the level of medical care, all of a sudden we have a different sort of paradigm shift. And the evidence shows quite clearly, actually, that when we do provide that kind of integrated care, whether it's in a skilled nursing facility or whether it's in someone's home, that people feel better, they do better, and the system saves money at the same time. So everybody wins, and not surprisingly, those who are cared for themselves have much more satisfaction. So we can do this, and we have the models. It's just a matter of rabble-rousing and trying to make sure that we can get these services paid.
Well, the good news is because of modern technology and modern medical advances, we're all living longer, but with chronic illnesses. And because we're living longer, we're going to also have some cognitive challenges as well. So I agree that, oh, by the way, my name is Christina and I work for a home care agency. So I do agree with everything that you all said. One of the big concerns that I have is that a lot of private caregivers go to the home and they, number one, may not have the education or the training to do things properly. They certainly don't have the licensure or the insurance or the bonding in case things go wrong, and oftentimes they're paid under the table, so they're not even getting acknowledged through our social security system that they are paid, because all of it's under the table. So I think that 85% of these women that are in the home care industry are being given a bad situation over and over and over again, especially if they're working on their own. They may think they're making a lot of money up front, but then later on in life, they have nothing to fall back on. Can you talk a little bit about what percentage of the home care industry is private care versus through agencies, either one of you?
I don't have the data, but I can look it up, and I think there are, I just read about part-time, but I don't really know how many of them are just work on their own. but it was to look at it.
Yeah, some of the data is kind of disease specific. So the Alzheimer's Association has in their big annual report sort of published a measure, and I can't remember exactly how much. It's certainly in the millions upon millions of dollars of unfunded caregiving, personal care that is provided to persons living with memory disorders annually. So, I don't know the breakdown between agencies and sort of private pay versus just family members, providing tremendous amounts of care. But it's certainly the case that it is a huge challenge and cost to the system in terms of people having to miss work and take FMLA. I fill out FMLA paperwork almost every week for family members who need to take the time to take care of their loved ones. So we don't do a good job doing that as a society.
One last question to the two of you in medicine. The psychiatrist anthropologist Arthur Kleinman at Harvard had his eyes opened when he became the personal caregiver for his wife for 5 years with dementia. And since that experience, Dr. Kleinman has suggested that were he to be in the position to redesign medical education, he would actually have the entering medical student begin by learning hands-on caregiving. And only after that experience would he add into their education the science, the knowledge about disease and things like that. Michael, in effect, you did that in your gap year. But what are your thoughts about that and the kind of contribution? Kleinman also suggests that this kind of hands-on caregiving has the potential not only to at times frustrate things, but to make us more human.
I would definitely have to agree with that. I think ultimately, my experience has been very valuable in being there kind of on the front lines and, having the experience as a caregiver. A lot of the skills that I used, I won't necessarily, continue to use throughout my medical career, but I think certainly giving me a much greater appreciation of what it actually takes to take care of somebody and sort of the challenges that do take place at home and even in the hospital. I think especially as a physician, it's easy to kind of walk in the room and, check on somebody and write your orders and then you just kind of disappear. But to really be able to kind of sit back and think about, what actually is going to have to be done for this person to stay at home, or, do they need to go to a facility, or are they going to be able to get the care they need? So, personally, I would definitely be in favor of kind of implementing that into the curriculum if possible.
So briefly, I would completely agree. I think that the other side of the coin to medicalization is technologization. It's kind of a mouthful, but and I think that other wonderful writers like Arthur Kleinman and people like Abraham Verghese have reminded us that often when we are in the patient role, we feel like we're eye patients. And I think when we care for another in the way that the people in this film do, and the way that Michael has done, and probably many of the people in this room have done or are doing, we learn much more important things sometimes than what we can learn staring at a computer. So that's the future.
Good, thank you so much. We're going to have to close. Now, please join us next week for a program on preventing gun deaths, a public health perspective. Our guest will be Dr. Stephen Miles from the University of Minnesota. And please join us then. Now, please join me in thanking Michael Warwick, Erin Yao, and Justin Mutter.